The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening. Welcome everybody to tonight's special edition of Question Lab. Tonight we're going to be tackling questions related to respiratory, connected to step 1. So this is great, important, high yield stuff. So we are glad that you have decided to join us. My name is Jeff Downing, and I will be guiding us through some of the trickier step 1 questions on this topic. And we are very fortunate to have Dr. Abraham Titus with us tonight as our guest expert. Abraham, would you like to say a few words to introduce yourself?
Sure. Thank you, Jeff. My name is Dr. Abraham Titus. I'm a hematology oncology fellow at the University of South Alabama. I've been a tutor with Scholar RX for many years now, actually, and have tutored many students such as yourself through step 1, step 2, and even step 3. And I hope that today's question lab is super helpful. Learn some high yield respiratory facts and concepts and things that you can take away. And even if you guys don't get the question right, there's something to take away from this. That's the whole point of question lab today. Look forward to it.
You know, our goal tonight is to help you tackle respiratory concepts effectively so that you feel more confident when you face similar questions on the exam. And, you know, again, we appreciate the interactive nature of this, but you know, we're really hopeful that we can help underscore, you know, our methodology, because you know, part of what we teach in Question Lab is, you know, how to approach these questions, how to slice and dice them. And there's a lot that you can gain in terms of knowledge, but we also want you to be thinking about methodology. So as we go through these questions, we're going to do it in a stepwise fashion. And we're going to follow some of the concepts that we've honed here at USMLE-Rx and as the you know, authors of First Aid have done over the years. Okay, and regardless of what you choose to adopt, you know, we think it's really important for you to have a set method for attacking every question, and then to practice that over and over, and obviously answer tons of questions in the lead up to your exam, just so that you don't have to think about how you're going to answer a question, that you really become a question answering machine. So with that, what we're going to do is we're going to open up tonight's question lab with question number 1. And when we go through these questions, the first thing you're going to notice, especially if you're a newcomer, there's something missing, right? What are we missing? We're missing the answer choices. And that's by design. So we encourage you to cover up the answer choices as your first step. And the main reason is that we want you to focus. We want you to focus on taking these questions, you know, one step at a time. And if you start looking at the answer choices and you see an answer choice that you don't know, or that you haven't studied, or that maybe it's given you trouble in the past, it could rattle you. And, you know, and especially if, you know that you've got tons of blocks on test day. So we say, let's focus, cover up those answer choices. And then step 2, we want you to read the lead-in. And the lead-in is the actual question. So in this case, the lead-in reads, which of the following is most likely to be seen in this patient? Okay. Now, you know, some students like to read the vignette first, but by reading the lead-in, now you can really home in on the kind of information you should be looking for, right? What is, you know, what is the type of answer that they're looking for? What is the type of information that you need to be, you know, really keen in on? So we say read the lead-in, and then now once you've done that, we can read the vignette. And the vignette is the actual scenario. A 61-year-old man presents to his physician because of shortness of breath that has worsened over the past year. He also has a dry cough and decreased exercise tolerance. Physical examination reveals increased convexity in the patient's fingernails. End expiratory crackles are appreciated bilaterally at the bases of the lungs. CT scans of the chest are shown. So again, the question, which of the following is most likely to be seen in this patient? Think about how many steps you think it's going to take to solve this one, as I pass it off to Abraham.
All right, guys. So we have a kind of a classic respiratory question. You have CT scans available of the lungs. And you have a question asking you what's most likely to be seen. So you want to use the history. You want to look at the images, and you want to build a picture in your mind. So let's go through and let's highlight some of the keywords in this question that would point out what we're looking at here. So again, let's start with the lead-in. Most likely to be seen in this patient. So it's not necessarily asking you the underlying diagnosis. It's not asking mechanism of action. It's asking what else can be seen in addition to what's going on. I always like to highlight age and demographic. 61-year-old man. It helps me kind of build a mental picture. Shortness of breath over the past year, right? That's how long it's been going on for. It's not something that's been a week, not been a month, a year. A change is what I'm thinking about. Dry cough with exercise intolerance, right? Decreased exercise tolerance. That tells me something's going on. Increased convexity of the patient's fingernails, classic physical exam finding. What does that mean? What does that connect to the picture that's going on? And then you have end expiratory crackles. Okay, it's bilateral. You can see that as well. And then the CT scans are shown. So if you look at the CT scans, it should kind of jump out to you, even if you know you're not to be the best at reading CT scans, especially for step one. You just have to kind of recognize typical patterns. Lungs don't look like that. Things in the black are our lungs here. They shouldn't look like that. They look like they got some stuff in them. There's a buzzword there that associates with that lung finding. With the combination of the picture, you should already have differentials in your mind, what the diagnosis is. But that's not what the question's asking. What's likely to be seen? So let's open up the options and let's try to make that connection to what's going to be seen in this patient. So we have option A, elevated aspartate aminotransferase levels. AST is elevated. Option B, elevated hematocrit level. Option C, elevated intracellular chloride level. Option D, positive purified protein derivative test result, which is PPD, positive PPD. So all these mean something different. Each of these are associated with a different condition, and you need to think about those as well. Even if you know the answer for sure, boom, it's easy. Think about how the question could be changed in order for the correct answer to be the right answer. But if you're not sure what's going on, look at the story, look at the CT scan, connect the dots to make the diagnosis, then think about, if that's the diagnosis, what else can I see in this patient? All right, take a second, read it, and Jeff's going to pop up the poll in 1 second.
Okay, everybody, take one last look. Hopefully you already have a good feel for what the answer is. So I'm going to go ahead and launch the poll and let us know. What do you think is most likely to be seen in this 61-year-old male patient? We'll remind you that on test day, you're not going to be penalized for your wrong answers. So never leave a question unanswered. And we definitely want to hold you to that during question lab. So even if you don't know this one, or maybe you're a little confused, again, that's okay. This is a safe learning environment. Okay, closing the poll. And let's see what you guys were thinking. So interesting, we got a very heavy response here for answer choice B, elevated hematocrit level. And then really for the other three answer choices, they kind of almost split the vote there. So, okay, so we've got a really strong consensus. So what we're going to do is hide the results and let's reveal the answer. And the answer is indeed answer choice B, elevated hematocrit level. So great job, everybody. That is the way to get it started. Question lab. If you didn't get it right, that's okay. That's why we're here. So what we're going to do is have Abraham walk through the answer.
Okay, well, great job, guys. Again, this is a relatively straightforward question. So that I'm glad you guys got that all right, most of you guys. But even if you didn't, don't feel bad. This is a learning concept. And even if you did get it right, let's go through the other options and see what those options are trying to point at and what's going on in the situation. So first of all, we need to diagnose this guy, right? This guy's got a bunch of junk in his lungs, shortness of breath for over about a year, and he's having nail changes as well. Okay, let's start going by one. So shortness of breath for over a year, that's a chronic issue. So something you got to think long term. So not like an acute pneumonia, nothing like that, or PE. Think more long term stuff, right? So, and the thing in the fingertips is happening is called what we call clubbing. So he has digital clubbing, and if you look at the CT scans, you see what's called a honeycombing pattern. It's like interstitial fibrotic honeycombing pattern. The lungs are scarred up, and it looks like a restrictive lung disease. This is the connection. So this is what we call idiopathic pulmonary fibrosis. There's no clear risk factor, right? You're not saying that, hey, I worked around hazardous material, I inhaled a bunch of chemicals, or I'm working around exotic birds or anything like that. This is idiopathic pulmonary fibrosis. You have progressive dyspnea, cough, the digital clubbing, the expiratory crackles in the lungs, and the CT scan that shows the honeycombing, right? The combination of those is what we can do without a clear, obvious thing. We're going to call it idiopathic, which means we don't know exactly what it is, pulmonary fibrosis. Now, typically happens in elderly populations. 55 over is the standard age. And we want to think about what their PFTs will look like. Since it's a restrictive pattern, it's going to have an elevated FEV1 to FVC ratio. All right, now let's get to the second part of the question. What's likely to be seen? So we diagnose this guy with idiopathic pulmonary fibrosis. Well, elevated AST, option A, what would that point more towards? Think about what would have a lung and liver association and cause elevated AST. So that they're probably trying to get more towards a centrilobar, pan-acinar emphysema. So the emphysema that's secondary to alpha-1 antitrypsin deficiency can lead to both liver dysfunction and a COPD. The CT scans in the picture doesn't really scream COPD to me. And there's nothing else indicating that this person is having a pan-acinar emphysema. So that option would be out. Option C, elevated intracellular chloride levels. What would that indicate to us? Defective chloride channels, right? That's cystic fibrosis. We're not going down cystic fibrosis route. Think about bronchiectasis, think about loss of secretions, thick mucus, think about recurrent infections in childhood. That's going to be a story. This guy's 61, getting it much later. You're not going to be CF as a dummy. Option D, positive PPD. You're thinking what? TB, right? Those are classic tuberculosis. You're going to lead to that, upper airway, upper lungs, gone complex, all the classic stuff we expect in TB. Not what's going on here. This is a straight up situation where he has idiopathic pulmonary fibrosis, and due to that, he has chronic hypoxia, which then causes the elevated hematocrit. So elevated hematocrit is a great answer for anyone with any chronic lung disease because they're chronically hypoxic. The body tries to compensate by increasing erythropoietin. Therefore, my hematocrit will climb. Great job, guys.
Yes, very good. It's a good one to start off the evening. And it's nice to get the ones with images. We've got a couple of those for you tonight. So with that, let's go ahead and move on to question number 2. Okay. So once again, we have covered up all of the answer choices, and we are going to start by reading the lead-in. Which additional finding is most likely to develop in this patient? Okay, so again, you're going to be, kind of what you're going to be looking for, or what you're going to, need to be imagining as you work through this particular patient story. So let's read the vignette. A 65-year-old woman comes to the clinic because of a drooping eyelid and occasional hemoptysis. She has a history of smoking. On physical examination, the swinging flashlight test shows her right pupil is 2 millimeters and her left pupil is 5 millimeters. The patient's right upper eyelid obstructs the view of the pupil. X-ray of the chest reveals a lung tumor. What additional finding is most likely to develop in this patient? I'd love it if you could go down to the question box and let us know how many steps you think this one is going to take in order to solve it. And what I'm going to do is pass it on to Abraham.
All right, so we have a classic presentation here. Don't be shocked if you don't recognize it right away. It'll get easier as you see, maybe kind of talk your way through it. But let's highlight some keywords here. Let's figure out what's going on in this 65-year-old woman who's having some weird eye symptoms with a cough, right? So a 65-year-old woman, again, high yield, drooping eyelid and occasional hemoptysis. Hemoptysis is never a good sign, right? So what does hemoptysis mean? Coughing up blood. If someone is coughing up blood, that is not a good sign. There's something going on. Where is his blood coming from? They do this flashlight test, and they show that her right pupil is 2 millimeters and her left is 5. Okay, so which one is where the problem is at? You guys are thinking about that. And the right upper eyelid also obstructs the view of the pupil. So what does that mean? An X-ray reveals a large tumor, so of the lung tumor, right? So you have to think about connecting these dots, and it seems like a pretty straightforward question, but there is also the next level to it. So the first level to this is, let's come up with a diagnosis. What's going on? There's some kind of lung tumor. She has a bunch of eye symptoms, and she's coughing up blood. What additional finding is most likely to develop? So let's look at the options here, and let's try to figure out what's going on. All right, so we have 5 options here this time, so it's a little bit more challenging, and hopefully you guys are still able to get to the answer correctly. Let's go through the options and figure out what's going on. So option A, adrenal insufficiency. Option B, easy bruising. Option C, high serum osmolality. Option D, hypocalcemia. And option E, jugular venous distension. Now again, just like the last question, each of these options are trying to hint at something, and there are something about this patient that could lead you down that direction. They're all distractors for a reason, but only one of them will truly kind of fit with this clinical scenario. So look at the full story, understand the situation, look at the eye symptoms and the X-ray, and try to find what is most likely developed in this patient. Take a second, review this, and Jeff will throw the options up in 1 second.
Okay, hopefully you've taken it all in and you've got your answer in mind. So what I'm going to do is I'm going to launch the poll and give you a chance to let us know what additional finding is most likely to develop in this patient. And let's share the results. Okay, so once again, a pretty strong consensus behind one of the answer choices. About almost over 50% of you went with jugular venous distension as the additional finding that you think is most likely to develop in this patient. Hypocalcemia almost pulled in 20% of the vote, and then the other 3 options hovering around 10% apiece. Okay, so again, pretty strong opinions here within the crowd. I'm going to hide the results. We're going to go ahead and share the correct answer, which is answer choice E, jugular venous distension. So kudos, everybody, off to a great start. Now this one, not as many people got it right as we did with the first one, but again, very strong showing. So if you didn't get it right, that's okay. Abraham's going to walk you through the explanation. Abraham?
Yep. All right. Thank you, Jeff. So great job, guys. Another one that you guys, more than 50% of you guys got the correct answer. This one's a little bit trickier, but again, it's one that they expect you to get without any questions. You guys should feel comfortable with these kind of questions, figuring out what's going on and then taking it from there and figuring out what additional finding they have. So let's work through this question. Let's diagnose this patient. Can somebody in the question box tell me the diagnosis of this patient? The 65-year-old woman with this lung mass that's having this drooping eyelid, there's hemoptysis, and irregular pupils. Wait a couple seconds, and we'll continue to talk about it, and I'll keep an eye out for the question box if anybody can get the diagnosis. So let me kind of break down what the buzzwords are in here. So when I'm looking at 2 different size pupils, one of the pupils has an issue, right? Right, and I see someone call it Pancoast tumor. That's exactly what this is, right? This is a Pancoast tumor. So this is an apical tumor that's happening from the lung mass that's pushing on the sympathetic chain ganglion that runs down there. And it leads to a syndrome called Horner syndrome. Great job, guys. Yeah. So this is Pancoast tumor leading to Horner syndrome. Very classic. This is one of the most commonly tested things on step 1 for pulmonology. It combines multiple topics, knowing the cancer side of things, knowing anatomy side, the sympathetic chain ganglion is what's compressed, and knowing the neuro side of things that, okay, which sympathetic effects are there? Well, you get the mnemonic PAM, right? Remember from first aid, PAM mnemonic, P-A-M, ptosis for P, anhidrosis for A, and meiosis. Anhidrosis is always difficult to explain, so they're never going to give you that as an option, but they'll give you the typical ptosis. So his right pupil, her right pupil is ptosis, so it means drooping, and also he has meiosis, has pupillary constriction, the 2 millimeters, and at the same time, that's the main issue here. So that's what they're trying to show here. They're trying to hit on that. Good. So we got the diagnosis of Horner syndrome secondary to Pancoast tumor. So what additional finding are they likely to develop? Let's look at the options. So as you guys said, jugular venous distension is the correct answer, as it makes sense. As there's a mass up there squeezing on things in the neck area, it's going to affect the not only the sympathetic chain ganglion, it can squeeze on things like the superior vena cava and cause facial swelling and jugular venous distension. That's superior vena cava syndrome. It can affect things like the diaphragm by damaging the phrenic nerve and causing diaphragmatic paralysis. It can squeeze on the recurrent laryngeal nerve and lead to hoarseness of the voice. So there's many different presentations they can give you, but the idea is you have a mass at the top of the lungs that's squeezing on things in the neck. That's called a Pancoast tumor. And that explains what this is. What are these other options trying to point at? Adrenal insufficiency? No, right? That's a problem with my pituitary gland either not functioning properly or my adrenals not functioning properly. So it can either be to a low secretion of ACTH, or the hypothalamus is not secreting CRH, or the adrenals are directly failing, right? That would be adrenal insufficiency. Easy bruising, think more coagulopathy stuff, either platelet dysfunction, things like that. That would explain that. High serum osmolality, that's a hypernatremia situation, right? So that's dehydration, diabetes insipidus. That's what you want to be thinking about. I thought some of you guys picked that when you guys were going down the high osmolality, and I think some of you guys were going down the SI-ADH route, and that's not where this is going. Right? High ADH would actually lower osmolality, so that's the trap there. And then hypocalcemia, again, this is going down the secondary hyperparathyroidism or hypoparathyroidism directly. So calcium being lost can be secondary to diuretic use, and many other reasons why calcium can actually be low in this situation. But in this situation, there's no question about it. It's JVD. There's a neck mass squeezing on things in the neck. Other things outside from the jugular vein distension you can have are going to be phrenic nerve involvement, which can lead to diaphragmatic paralysis, or recurrent laryngeal nerve involvement, which leads to hoarseness of voice. So those are also high yield and can also be options in this answer. But great job, guys. Let's ramp it up with the next question.
Yep, nice work, everybody. We're at the halfway mark. So what I want to do, give you a chance to stand up and stretch. And while we do that, want to take a quick moment to talk about the resource that we've built to help you smooth out your USMLE prep, and that is USMLE. We've designed an all-in-one solution that students have been using for step one for, going back almost 20 years now. And our tool was created by the authors of First Aid, and it is designed to help give you everything you need to succeed. So within our RX 360 Plus package, that's our complete study system. So it includes all of our RX bricks, so over 900 digital learning experiences to help you build your foundations of medicine. We have our new and expanded QMAX. So our question bank now has over 4,600 USMLE style questions for step one and step two, and all of them with detailed explanations to help you understand how to reach the answer. Plus, we have 2 self-assessment exams for step one, and we're in the process of building a new SAE for step two, which we're planning to release here later this year. We've got over 1,300 express videos, which are perfect for covering the key high yield concepts quickly. And then we've got our flash facts system, over 13,000 flashcards designed to help you review and memorize and reinforce really important details. So what really makes USMLE-Rx stand out is the seamless integration. So again, whether you're just starting out or you're looking for a tool to help you get to, maybe you've got CBSE is coming up, or maybe you're just looking to kind of see where you're at, you can join the tens of thousands of med students who trusted USMLE-Rx to help them reach their goals. So with that, let's go ahead and get into the second half of tonight's question lab. And once again, we've got all of those answer options covered up. And we're going to go ahead and start with the lead-in. Which of the following is the most likely cause of this patient's presentation? Okay, so you know kind of what we're looking for. This isn't something that's straightforward. We're actually going to be looking for the cause here. So with that, let's go ahead and read the vignette. A 65-year-old woman comes to the emergency department with shortness of breath and blue lips and fingertips. She has a history of myocardial infarction, for which she currently takes sublingual nitroglycerin. There is chocolate-colored blood on her sheets. Her arterial blood gas shows a pH of 7.41, partial pressure of carbon dioxide of 41, partial pressure of oxygen of 95, and oxygen saturation of 80% on room air. So again, which of the following is the most likely cause of this patient's presentation? With all of this information, think about how many steps is it going to take you to answer this one. Let us know down in the question box as I pass it off to Abraham.
All right, thank you, Jeff. So this is another 65-year-old woman. So we're kind of staying in the same age group range. Let's look at some high yield points in this question here. Again, she's coming to ED, right? So it's a little different. Blue lips, fingertips. Okay, that's kind of some key important thing here. She takes sublingual nitroglycerin. Ideally, I should highlight that as well. That's something important as well. So she's on MI, sublingual nitroglycerin, blue tips, fingertips, and she has chocolate-colored blood on her sheets. That's interesting. Has a arterial blood gas of 7.14, right? So what does that mean? What are my normal ranges? You got to start thinking about that as well. Carbon dioxide is 41, oxygen is 95, but her oxygen saturation is only 80%. So why is that weird? How come I have partial pressure oxygen 95 with an oxygen sat of 80%? Something's not adding up. Now, you have to kind of see the full picture here, right? These are like very short to the point questions, but a lot of dense information is packed into these questions. As you'll see, as you move to step 2, the questions get a lot chunkier, a lot more in depth, and a lot of extra garbage thrown in there. But these kind of step 1 questions are kind of what's most high yield to really get some of these studying points across. So let's think about this one and let's move forward about what's most likely cause of the patient's presentation. Let's go through the options and let's try to pick an answer. So option A, G6PD deficiency. Option B, increased carboxyhemoglobin. Option C, increased deoxyhemoglobin. Option D, increased oxidized iron. Option E, a VQ mismatch. Now, all of these are good options and they kind of explain different things that's going on. But in the patient who's having this chocolate colored blood, fingertips that are blue, history of an MI, taking nitroglycerin, having this weird like discorrelation between the partial pressure of oxygen and her percent sat. What does that mean and why? How can I explain that from a physiological standpoint? It's a classic physiology pulmonary question. So take a second, process what's going on, look at the options, and work through it. This is another one where if you know it right away. If you don't, then we can talk about it more in detail.
Okay,
right.
I'm gonna go ahead and launch that poll. If you don't know it, that's okay, but you don't want to leave it unanswered. I'll give you 3 more seconds. I'm going to close the poll. Okay, closing the poll now. So let's share the results. Okay, so unlike the first 2 questions tonight, we don't have strong consensus behind our answers here. It looks like most of you ruled out the G6PD deficiency, but we almost have practically a 4-way tie, or maybe it's closer to a 3-way tie, between increased carboxyhemoglobin and increased oxidized iron. Those are kind of tied for first, with increased deoxyhemoglobin right behind it, and VQ mismatch not that far behind that either. So, so this question a little trickier. And what we're going to do is we're going to hide the results, and they're going to share the answer. And the answer is answer choice D, increased oxidized iron. And, by the rules invested in Question Lab, this did tie for first. So we're going to give you guys the W for this one, and we're going to call it 3 for 3. But we know this was a lot trickier, and most of you got this one wrong. So this is why we're here. We're here to learn, and we're here to have Abraham kind of walk us through this one. Abraham, show us what we need to know.
All right, Jeff. So this was definitely a trickier one, definitely a step up from the last two questions. But I'm glad a lot of you guys are still thinking the same route, ruled out G6PD, which is not really fitting the situation. But the other four options, yes, they are really good distractors, and there are a few things that separate each other. And that's what you need to learn. And that's why I love this kind of question, where you really learn not only one thing, but four things from this question, where each of them kind of point towards something different. And how can this question be written differently for each of those to be right? Because the classic someone showing up short of breath situation is very common, and you have to figure out what's going on. So buzzwords in this, like we talked about, are going to be the blue fingertips and lips, the fact that she's taking nitroglycerin, and the chocolate colored blood. And then based on her ABG, which shows the pH, carbon dioxide, and oxygen, there's this weird discrepancy between her percent sat and her oxygen in her partial pressure. So what are some buzzwords that are going to point towards the answer? So she has cyanosis, chocolate colored blood, and then the oxygen saturation is low, but the partial pressure of oxygen is normal. Same with the carbon dioxide. So this is what we call methemoglobinemia. And they didn't do that on purpose, right? They didn't call it carboxyhemoglobin, deoxyhemoglobin, methemoglobin. They just said increased oxidized iron. Understanding the concept of methemoglobinemia is very high yield in this situation. So methemoglobinemia happens when iron, because we know iron is the most important part of hemoglobin, which binds to oxygen, gets oxidized, right? So something like nitroglycerin can oxidize it. Local anesthetics like lidocaine and benzocaine, all these guys can do it as well. I had a question where they're like, oh, I had a baby who's having pain with her teeth growing out, so they put numbing cream on her gums, and that can then get absorbed systemically and cause oxidization of the iron from a ferrous form, which is Fe2+, right? The 2+ on the top. Ferrous iron to ferric iron. How I remember this from step 1 all the way till now is ferrous is 2 people, so me and you. And they always have to say 3 is a crowd. So ferric is icky iron. Ferric iron is 3+. So 3 is a crowd, that's too much. That's 3+ iron is bad iron. Ferrous, Fe2+ is a good iron that we want. So when I have all this exposure to nitroglycerin or local anesthetics, that can then get absorbed systemically, that can then convert that ferrous iron to ferric iron. And ferric iron doesn't bind to oxygen nicely. And when hemoglobin doesn't bind to oxygen nicely, the blood turns darker, you get more cyanotic. When I'm checking for partial pressure of oxygen, I'm looking for oxygen floating around in the blood. There's no problem getting oxygen into the bloodstream. So the PaO2 is okay, 95 is fine. But that oxygen is not saturated. It's not binding to the hemoglobin. And that's why that's 80%. So that discrepancy is a big, big clue, on top of the fact that he has cyanosis and she has been taking nitroglycerin. Those are the big pointers, all pointing towards, hey, this is methemoglobinemia. And the treatment for methemoglobinemia is methylene blue, right? Meth for meth. Methemoglobinemia, methylene blue. That's the treatment. So that's all high yield points, all very easily testable. Very step 1, bang, bang kind of questions. Let's look at the other options. Option was A, everybody ruled out, almost everybody, and that's G6PD deficiency. Really, this is not really fitting the picture of G6PD deficiency. You want to think about some kind of trigger that's pushing it to a hemolytic anemia, bite cells, jaundice, lots of things like that that would point more towards this. He wouldn't explain the chocolate color things. He doesn't have cyanosis. None of that stuff would be seen in G6PD deficiency. More of a jaundice picture. Increased carboxyhemoglobin. What is carboxyhemoglobin? That's carbon monoxide. And that's a very good differential. And you should always think about carbon monoxide poisoning whenever I think about methemoglobinemia. They have similar presentations because they can also drop my oxygen saturation. So what can I think about it? Well, the difference is you're going to have red skin, red lips, because even though oxygen isn't directly binding to my hemoglobin in carbon monoxide poisoning, the carbon monoxide is binding to my hemoglobin. So my hemoglobin stays red. My blood stays nice and red and bright. That's why people that have carbon monoxide poisoning, their labs will look completely okay, and they'll be red in color. They won't be cyanotic, and that's a different picture. That's gonna be somebody who's locked himself in a garage and fell asleep with the heater on, or left their car on in the garage and passed out, things like that. Increased deoxyhemoglobin. So that is when the absence of it bound to oxygen, right? So it leads to peripheral cyanosis, and it wouldn't have that chocolate color that you see in methemoglobinemia. Okay, so this is not a bad differential as well, but deoxyhemoglobin is just hemoglobin that doesn't have oxygen bound to it. Here in this situation, it's because the hemoglobin has been oxidized and the iron has changed shape. That's why it's not binding to it. It's a little bit different. And the best answer would be increased oxidized iron. VQ mismatch, many things can cause that. A shunt, creating dead space with a PE, things like that. Many things can cause that. And in this situation, that chocolate colored blood is not seen in these situations. And you would kind of have a different picture, right? You have either a PE story, something about a shunt being created, nothing like that. This picture is straight up pointing towards that this guy took nitroglycerin and now he has methemoglobinemia. All right, guys, hope you got that from that. That's a long, wordy explanation, but very high yield. All those points are very important.
Yes, that was a good one. Okay, so we're here. We're at the end of tonight's event. We've got one more question, and we're going to go ahead and reveal it here in just a second. So let's go ahead and reveal question number 4. So again, we've got an X-ray here, and we've covered up all of the answer choices, and we're going to start with the lead-in. Which of the following pathologic processes is most likely occurring in this patient? Okay, so we already know we've got the X-ray here, and we know that there's some pathologic processes going on. So now that we kind of have a sense of what we're going to be looking for, we can read the vignette. A 34-year-old man comes to the emergency department because of a 2-day history of productive cough and fever. He says he wakes up from sleep covered in sweat, sometimes with right lower anterior chest pain that is worse with deep inspiration. He drinks alcohol heavily and has had 2 episodes of withdrawal in the past year. His last alcohol intake was 3 days ago, after which he was found passed out in a pool of vomitus. During the interview, he expectorates thick, foul-smelling sputum. His temperature is 38.1, pulse is 74, respirations are 18, and blood pressure is 112/74. Physical examination reveals crackles over the right lower lobe. The X-ray of the chest is shown. Which of the following pathologic processes is most likely occurring in this patient? Go ahead and hit the question box. Let us know how many steps you think this one's going to take while I turn it over to Abraham.
All right, guys. So we got another question here. This is a little bit different, a younger person, less chronic presentation, more kind of an acute presentation coming. 2-day history of productive cough, right? So let's break down this question here. Let's look at the X-ray and let's highlight some of the key important facts here. And let's get a better understanding of what's going on here. Okay. Again, the lead-in is pathological process is likely occurring. Okay. It's not asking about diagnosis. It's not asking about treatment. It's not asking about anything else. It's asking a pathological process. So this you can kind of understand. More basic science style question, right? You want to think of what's going on at more of a deep level, a microscopic maybe level. All right, based on this presentation, you got a young guy, cough, fever, and he wakes up from sleep covered in sweat, right? And it's happening for 2 days. So it's very much an acute presentation. He does have this kind of chest pain picture. It's worse with deep inspiration. That means something, right? Whenever I think chest pain, you got to think, is it affected with respiration? And you should have some differentials pop into your mind as soon as I hear that. Cough, fever, sweat, and chest pain worse with inspiration. That's a big differential. Okay, what are other important facts in this? He drinks alcohol heavily, and they found him lying down in a pool of vomitus. That's important. What would that indicate, and what would that put him at risk for? He expectorates thick, foul-smelling sputum. Okay, that's important. And he has a fever, like we talked about. Other exam findings, okay, he's not in shock or anything like that. His heart rate's okay. And he has crackles on the right lower lobe, X-ray shown, right? So let's say I'm saying, hey, I'm not good at looking at images. I just need some help. I just want to answer the question without the image. Well, if they tell you the symptoms are in a certain area, the physical exam shows that it's a crackles in the right lower lobe. Look in the right lower lobe, right? So you want to train yourself to use the vignette to help you with the image. They're not expecting you to be radiologists off the bat, but the more you look at them and the more you practice seeing what it's supposed to look like, it'll be easier. And there may be questions where you don't know what's going on from the vignette, but the image gives you the clue. So you need to be able to learn both ways. But in this situation, it tells you right lower lobe. So if I look in the right lower lobe, I see some opacity stuff, like white junky stuff there. What does that mean? And how is it shaped? Those are things you will learn. Even if you don't, X-ray is not telling you anything, the story should tell you what's going on. All right, so you should come up with a diagnosis in your mind at this point. And your next step should be, well, what pathological process is happening with that diagnosis? So let's look at the options and let's try to figure out what's going on. So again, we've got 5 options here. Let's work through these. Option A, pleural effusion. Option B, cryptogenic organizing pneumonia. Option C, esophageal perforation. Option D, liquefactive necrosis. Option E, non-caseating granulomas. Again, all these are pointing towards something. They all explain something. But in this particular situation, this patient, fever, productive cough, found down with vomitus, and has crackles in the right lower lobe. What am I thinking about? And what is happening at a pathological level that explains it. All right, take a second, think about it. And
okay,
let's
everybody
get to the answer.
Yeah, everyone take one last look. Hopefully you've already got your answer choice locked in. I'm going to go ahead and launch the poll so that you can tell us which of these pathologic processes is most likely occurring in this 34-year-old patient. Over 88% of you have voted, so I'm going to go ahead and close the poll. And let's take a look at the results. Okay, so almost half of you went with answer choice B, cryptogenic organizing pneumonia. And we've got kind of a fairly even split amongst the other choices, although I guess liquefactive necrosis came in second. And then the other 3 answer choices all pretty much split third place. Okay, interesting. Let's see how we did. So I'm going to hide the results and we're going to share the answer. And the answer is answer choice D, liquefactive necrosis. So that was the second place vote getter. So we didn't get this one, but that's okay because we knew this was a hard one, and we knew that there was a lot that we'd need to unpack. And thankfully, we've got Abraham here to do that for us. Abraham?
All right, guys, don't feel bad about this one. This was a tough one, and I purposely picked this one as the last question because it kind of requires some thinking, right? And a lot of you guys out in the question bank was actually dropping the correct diagnosis of what's going on just from the presentation. So whenever somebody has this like productive, nasty cough, and they're really hitting on the fact that he's an alcoholic and he's passing out, what should we be thinking, right? If he's lying down and imagine he's drunk and he vomits and then he inhales the vomit, call it aspiration pneumonia. These anaerobic bugs tend to get into the lungs when you have aspiration pneumonia. And that, especially over a few days, if they're leading to fever, night sweats, cough, to the fact that he's not getting better. And then on X-ray, we see this kind of pocket there, this like haziness you see on only the right side there, this white spot there. And that's really what's pointing towards an abscess formation. So he's having a lung abscess form from the aspiration pneumonia. So whatever he was doing, he was drinking alcohol, he probably vomited and he aspirated. The fact they found him lying in a pool of vomitus, that's a big clue. And that points more towards, okay, this is an aspiration pneumonia. Aspiration pneumonia leads to aspiration abscesses, right? Pulmonary abscesses, and I need to treat those. And when I think about abscess, am I thinking solids or liquids? Well, abscess is full of pus, it's liquid. And the type of necrosis you see in abscess is liquefactive necrosis. It's turning the tissue into liquid along with creating a pus-like pocket in the lung. And that's why liquefactive necrosis is the correct answer in this question. That's why I really highlighted the pathological process in this. Right? It's not asking for a diagnosis. Right? It's asking about what's the pathological process. A diagnosis here would be either aspiration pneumonia or lung abscess. They're both correct diagnosis. But this is caused by the liquefactive necrosis where the cells get completely digested, leading to this pus and necrotic tissue formation in the lung. That's secondary to anaerobic bugs getting into the lung from him aspirating his vomit or his oral bacteria. Let's look at the other options, right? The number one you guys picked was cryptogenic organizing pneumonia, all right? And I find that a lot of people end up picking this because they just don't really understand what that means. And they just like, okay, this is kind of a weird sounding pneumonia picture, and I think it's a pneumonia, so I'm gonna go with this. Well, cryptogenic organizing pneumonia means a non-infectious pneumonitis with inflammation. That's essentially the idea. So something is there. Crypto means fever, right? Cryptogenic, fever creating, organizing pneumonia, but it's not a bug. So in this situation, this is having purulent sputum and having fevers and having it associated with vomiting. That points away from this. You would think more of a non-productive cough, shortness of breath, fever that spans a longer time. And on the X-rays, you typically see patchy ground glass opacities, right, throughout the lung. It's usually bilateral, and it's like white patchiness, not thick white spot in one area, and you can hear the crackles in one area. That's going to be more of a liquefactive necrosis picture, abscess picture. That's why B is out. So B, think about a non-infectious pneumonitis picture, which presents like a pneumonia. That's what I call a cryptogenic organizer. Pleural effusion, again, the location for the fluid collection doesn't really fit with the pleural effusion picture. You would more likely see it at the border of the diaphragm. And you would typically see it in the CHF picture, cancer picture, other infections can cause it, like parapneumonic effusion. Not what's going on here, right? This is straight up an aspiration pneumonia, and they're really asking about what the pathology is behind that. Esophageal perforation, that's Boerhaave syndrome. That's alcoholic, sure, you can fit that picture, but you would get more of crepitus in the chest and air leakage in the chest cavity, not really a picture of productive sputum production and stuff like that. And non-caseating granulomas, I want you to think about sarcoid. I want you to think about other idiopathic, like inflammatory disorders that can cause like lymphadenopathies in the chest, and that could be the whole picture that they're going to focus on. More of a lymph node story. Here, you straight up see somebody with a vomiting history coming in with thick sputum, fever, and then on the X-ray, you see this white collection of fluid in the lung. And that's exactly what's going on here. This is aspiration pneumonia leading to lung abscess, secondary to liquefactive necrosis. Great job, guys. Even if you didn't get this one, this is a hard one. Make sure you guys just understand the concept and understand that cryptogenic organizing pneumonia is not a good answer if you don't know what's going on. Think about it. It has to be non-infectious and it has to be something that's a non-productive cough. Great job, guys.
Okay. Excellent. Thank you, Abraham. Yes, definitely. Great job, everybody. This is, it's all about learning. So well done. Hats off to all of you. Okay, so we do have, put it in the question box. So if you want to, again, review the questions and the explanations, do that. Or if you just want to grab the question IDs, you can screenshot it and write them down. Okay, so again, within USMLE-Rx, obviously we've got links to, bricks and high yield topics and express videos. So definitely more ways that you can deepen your understanding of some of the things that we covered during tonight's event.